You are listening to the global network of podcasters dedicated to the pharmacy profession. Welcome to the Pharmacy Podcast Network.
We have an aging population taking more medications than ever before. On this podcast, I will interview experts in geriatric medicine to gain insight so we can provide optimal care to patients in their golden years. I'm your host, Dr. Tamara Ruggles, and this is the Geriatric Pharmacy Focus. Hello, everyone, and welcome back to the Geriatric Pharmacy Focus. I'm your host, Dr. Tamara Ruggles, and with me today is a concierge pharmacist who has done so much for senior care pharmacy and also me personally in my career, Dr. DeLon Canterbury. We are so thankful to have you with us today, Dr. DeLon. And so a lot of people know you because you've founded Geriatrics. You're a concierge pharmacist. You're a speaker, a TEDx speaker, and you also teach healthcare professionals about deprescribing and the dangers of being over-medicated. And so tell us a little bit about your story, how you got to where you are, and just a little introduction for our listeners.
Absolutely. Yeah, it's always a pleasure to be here. So thanks for having me on, Tam. I started Geriatrics in 2020 after honestly not feeling very fulfilled in the community setting and frankly, really noticing how much of our older adults were being disturbed and just not having an advocate or not having a real voice kind of talk through some of their day-to-day, whether it's social or medical or transportation needs and whatnot. So, apart from working, for Big Box in Henderson, which, I actually enjoyed for a little bit, the meat and bones of it was, fill. And I think a lot of us are kind of tired of that model. And so, frankly, that got me a bit depressed and angry with the current climate of the health system of pharmacy, at least in that setting. And it got me into the world of geriatric medicine. Additionally, I had a personal story with this where my grandmother was given the wrong medication. She had mild dementia, moderate, and was given an antipsychotic, ziprasidone, and to manage her behavioral symptoms. Now, this was in a assisted living facility in New York at the time, and her symptoms really just got so much worse with the use of the med that the facility can no longer manage my grandmother's care. So my parents at the time, this is before I was a pharmacist, were basically putting 3 kids in college. My mom's a teacher, my dad's an accountant, and they had to move my grandma, Mildred, from Brooklyn down to Atlanta where we lived, and now had to become thrust into caregivers and now the experts of medicine, now experts of maneuvering a very complicated and intentionally convoluted health system. So doing all that, needless to say, after 4 or 5 months of caregiving hell, Granny just got worse and worse and worse and was irritable, sundowning and wandering. And it wasn't really until a Rite Aid pharmacist, when my mom went for a refill on that same ziprasidone, mentioned the symptoms she was having. And it gave that pharmacist an extra kind of red flag to look into the case and eventually advocate for deprescribing and get that medication tapered over a couple of weeks. So Granny Mildred got back to normal after that pharmacist stood up and called and fought and did something that really changed the course of her care. So she got better, her symptoms got resolved, and we were able to safely put her back into another facility back in New York. So my story is twofold, right? The personal with my granny, and then seeing it firsthand as a pharmacy manager in a pretty geriatric part of North Carolina. It just made me think, why aren't we as pharmacists directly working with the community? We have such an awesome niche and awesome skill set with the most accessible professionals, yet we have a growing population that, frankly, we don't have medication experts in. We have geriatric pharmacists, but hey, we have to wait until you're in a a nursing home or long-term care setting to even get that type of conversation going. So who better than, geriatric pharmacists and geriatric professionals to become the next wave of deprescribing advocates? So that's the origin story behind geriatrics. I quit Walgreens in 2020. I decided to start this company. Didn't know what the hell I was doing, and still, we found a way to serve our community and make things happen.
You sure did find a way. You're making a huge impact. But I just want to point out how awesome that pharmacist was that made such an impact on your grandmother's life, but then inspired you to change your kind of career path. And so also, pharmacists in any setting can be deprescribers. It doesn't have to be your own concierge business. It doesn't have to be retail, hospital. I mean, any setting you're in, a pharmacist can be a deprescribing advocate and just go above and beyond to make such an impact for our patients and then inspire, more pharmacists to do what we're doing. So let's get into deprescribing. A few questions about that. First of all, what is your favorite tool to use to aid in the deprescribing process for patients?
Yeah. I would say, so of course we have our, our explicit, implicit criteria. We got our Beers list, stop starts and stop fall. There are tons that we use that we're familiar with. For me, I'll be honest, I really love starting the conversation around the what matters most sort of 4M's aging-friendly mnemonic that I know ASCP is championing along with the Institute for Healthcare Improvement. I use that as a bedrock of all of my deprescribing convos. Like if you don't have a rapport built or at least an understanding of where your client or patient's coming from, it's really hard to enact that type of emotional change or behavioral change when it may come to having the deprescribing convo. So I like to lead everything with, what matters most to the client, how are we preserving mobility, how are we looking at the meds, and how are we preserving mindset. And so I tailor those answers that the patient provides to the deprescribing plan. And then we get into the nitty-gritty of, all right, the clinical pharmacy stuff. Okay, do you need to be on imipramine? No, probably not. Do you need to, so we're at the end of the day, we're doing, of course, drug-drug interaction checks. We're doing genetic drug interaction checks. We're looking for false risk assessments, anticholinergic burden, which is a really common one I like to use as well. It's just calculating that load. So it's an amalgamation of multiple tools. But I'd say when I'm trying to inspire or coach other caregivers or family members, I really like to reference the Beers list. I think because it's such widely resourced and quoted, I like to reference the Beers list and say, hey, just do like a control search if you're able to find a document and see if the name is in there. Or for just practical, when I'm in the office kind of consultation to a patient, I use the Vion model, which is is this medication vital for me? Is it important for my quality of life? Is it optional? Is it not necessary? Is it really, is the medication no longer needed? And then lastly, does every medication have an indication? So it's the VA's framework for deprescribing, but it can be used in all settings. It has been proven to be used in all settings from the caregiver standpoint, clinician, or family. So it's a number of tools. Yes, Tam, I like to use. Frankly, I think a good old drug-drug interaction check can do wonders, but to me, it's the empathy built into the conversation in order to get those other things moving or implemented. Yeah. I like to start with. So the 4M's
I'm so glad. I'm so glad you brought that up because I think a lot of pharmacists don't think of the 4M's right away. We do go to the anticholinergic burden and the Beers criteria and stop start. And sometimes we forget looking at a list of meds about the patient and what matters most to the patient. And that happened to me once because I was meeting with a patient and I'm looking through her med list. And to me, like amitriptyline, I see it right away. And I'm like, boom, we got to get rid of that. Like high anticholinergic burden. But when I talked to the patient, that was the one medication she did not want messed with because she
Mm,
went through a really hard time in her life, and that medication had helped her so much. She had like strong feelings about not getting rid of that. She wanted to be on that
mm, mm,
medication, and
mhm.
she wasn't concerned about the risks because she wanted that med. And so you bring up such a good point about, yeah, what matters most to the patient. That's the perfect place to start as far as a tool for deprescribing. What is your goal? What matters to you? And then we'll go from there
Mhm.
with these other tools we have. So I love that. But okay, so speaking medications, what are some of your favorite medications to deprescribe?
Yeah. Yeah. Favorite ones. You know, there's some softball ones like, yeah, you don't need this aspirin, you don't really qualify. Because I hate bleeds red. But I would say like favorite ones are like NSAIDs. Like I still kind of hate NSAIDs long term. Um, but there are challenging ones like certain psych meds, of course, benzos, opioids. Right now, we got a couple clients doing a Klonopin taper, and it kind of takes forever depending on the case. And it's going well, but if you've already got some baseline traumas and anxieties, I get more fulfillment from stopping those, especially if they've been on them for 10, 15 years. So I like to stop the ones that are really, really, really long-term use. I do enjoy stopping PPIs, um, so omeprazoles and Nexiums and such, and trying to switch to like Tums or anything else, frankly. But I would say I don't like blood thinners as much. Like there are, like for instance, there's some people who've had strokes where we don't realize this, but if you've had a provoked stroke versus an unprovoked stroke, uh, I think you have like 3 months of anticoag, and then you can actually stop. But most people, as we know, just stay on both. Like no matter your category, they're like, all right, you're on it for life. Whereas if it was a provoked stroke where we knew the source of how you had that, you have evidence in the guidelines that say you can actually stop this and reassess like, your risk later. But I do like giving people that aha moment that, hey, you can actually get off of this depending on the source of how you had that come about. So I love it all, to be frank. But favorites, yeah, definitely NSAIDs. Definitely that stupid baby aspirin people just took for no reason because they thought it was great. And yeah, I would say PPIs and like your Klonopins and then opioids for sure.
Yeah. There's so many that, just like come to mind when I think about deprescribing, but my favorites are just like those really easy cases where you're like one guy came in to the deprescribing clinic having hallucinations, and it was like the easiest case I've ever worked with. And we did dig
Nice.
into other things, but he came in and I'm like, "So what brings you here?" And he's like, "Well, I'm seeing people who aren't there." Well, okay. Like, when did that start? He's like, well, about 5 weeks ago. And I'm looking through his med list and I see pramipexole for restless legs. And I'm like,
Ah.
when did you start this? About 5 weeks ago. And I'm just like, yes, this was so easy. But I mean,
Yeah.
obviously we dug into other things, but I love it when the side effect is so easy to
Mm.
spot and then deprescribe that med and make such a big impact with just like I didn't have to do, 15
Yeah.
hours of research to know what it
Right.
was. So
Right.
nice. Such a treat.
Yeah. I love
Um,
that. No, you're right. Mhm.
okay, so we see patients with a ton of medications, but we also see those patients that are on a list of like supplements a mile
Mhm.
long. And I'm
Yeah.
certain they watch a Dr. Oz or read a magazine, see an infomercial, and all these supplements just start piling up. And pretty soon
Mhm.
they're like, I don't remember why I started that, but I just keep taking it. So what
Mhm.
are those supplements or vitamins? What are the ones that you tend to like hold on to and not deprescribe?
Mhm. Mhm. Yeah, I definitely get at least a recent lab history to see if there are any true deficiencies. um, yeah, the key ones I like to keep is a really good high quality multivitamin, like from Pure Labs or something. But other than that, vitamin D, generally a lot of us don't have it. So I'm a big fan of vitamin D. Um, I mean, there are some herbal supplements I really like. I mean, I do like elderberry. Like I like that. I don't have a problem with people using that. What else? Mag is also usually depleted, so I do see a good quality mag could be good. However, it does have its side effects, so I try to make sure there aren't any, quality of life issues there. But frankly, there are really like 3 to 5 key, I would say, supplements people should or can keep on that I'm not going to like press hard against. If I'm seeing 20 or 30, then yeah, we're going to shave off as much as we can. Because I've gotten some crazy referrals with 47 supplements and like 3 prescriptions, and they're getting crummier and crummier. And there's just so much quackery, unfortunately. And I'm not saying it's all bad. Of course not. It's just the environment we're in, your consumer is just not going to know how to get a quality source product, nor know the true benefit without having people like us really dig into the literature and at least see if it can help a client. So when I see that, I use an argument of, how much are you spending for this and still feeling worse, And so there are people who just take advantage and just say, well, you need to be on Chromium forever. And it's like, no, there's just some things you don't need forever.
Right.
So
That's right.
everything has a timeline. So if we're discussing timelines, cool, no problem. But some people are deficient. So yeah, you can treat. But yeah, I think that's more patient preference. But there's a lot of this, just false sense of security and safety, especially if you're not looking at the whole picture of how you can really just put this into your diet. And if you eat your rainbow, frankly, with lifestyle medicine, nutritional medicine, like that's really the key, is getting that in from another source, because it's not even as bioavailable in these pill forms. You may as well eat those things you're trying to supplement. So that's what I like to enforce first. And then if you have to, then consider, keeping on maybe a vitamin D, a good quality multivitamin, occasional mag, those are my core ones.
Yeah, I would agree. I like to stick with the vitamin D, especially we're in North Dakota and we don't see a lot of sun for about 6 months of the year.
Yeah.
So I agree with the vitamin D. I do like a good B complex or an activated B12 for especially those patients on those B12 nutrient depleters,
Oh, yeah.
oral contraceptives, proton pump inhibitors, metformin, things like that. So yeah, methylfolate for those with an MTHFR deficiency, but I'm kind of on the same page with you. Look at those things that, are probably depleted, but we don't need to go crazy. I've had a few interesting patient cases. One of my nursing home admissions came and she had a very bluish tinting of her skin. And she was taking colloidal silver 6 times a day, every day, and it did turn her skin a bluish color. And I enjoy colloidal silver every once in a while if I have a headache or something. But yeah, she really went all out with that stuff, and it did turn her skin blue. I've had another patient that was on, a good 20 supplements and ended up in the hospital with some liver impairment. And then once they were all DC'd, her LFTs returned to baseline. And so she had some liver injury from it. So I am, I like it to be, all around. I like to be balanced as far as, there probably are some vitamins and supplements that you might need. There's probably some prescriptions you might need, but let's just take a whole picture and do, the minimum necessary to treat your condition for sure and make you feel good.
Definitely.
So I think a lot of people are really interested in your business with your concierge pharmacy and just working with patients one-on-one. I know a lot of people are interested in starting that type of thing. So one of the major questions I get is, how do you recruit patients?
Yeah, that's a great question. And, damn sure wasn't sure how to do that in the beginning, apart from doing what I learned I could do best, which was going straight to the people that need it. So when I started, one of the things I learned from my coach was to talk about the problem. And, I talk all day about, polypharmacy over prescribing. So one thing I find as clinicians is we kind of tend to do that amongst each other. It's like, yeah, we talk about it at ASCP, we talk about it at these conferences or CEs, but like, are you going to the people that need to hear it? And so I started really with going straight to nursing homes. I went straight to retirement communities and asked them to basically pay me to talk about how I can help them. And so I became a part of the programming for these retirement independent living communities. I would then use that as a segue to talk to their clinical staff and say, hey, on the ALF side or skilled nursing side, can I talk about the same topic, to your staff to get your clinicians on board? So I don't advise everyone to do what I did. I did a lot of scorched earth, scattered shotgun approach and just did multiple different things where today I tell my students to just stick to like one or two core settings that you want to make yourself known in. But I went and literally spoke to everything that fueled my passion, which was a problem because I'm scattered. So it was nursing homes, right? I did that. I did a whole circuit of, all right, who are my nursing homes in a 50-mile radius I can drive to, talk for an hour or 30 minutes for $250 or $500 just to say, hey, here's the problem. Did that for a while. Then I pivoted to nonprofit groups. And so since my grandmother had dementia, I started working with the Parkinson's Association of North Carolina, Dementia Alliance, like other local grassroots nonprofits that align with my clinical interests in terms of health conditions, but also in the population that needs to hear it because they have, masses of people who don't know. So I did that for quite a bit. Then I started speaking to caregiver support groups. Then I started speaking with church groups. Then I started doing more of a national regional reach, fraternities, sororities, Masons I spoke to at one point. I started just talking everywhere. And I learned, that builds word of mouth, that builds reputation, that builds kind of a referral base. But the mistake I made was like talking to them once and then, all right, bye, I'll see you later, versus nurturing the relationship throughout the years of me in business. So that's been my refocus this year, was sticking to like a demographic. Like, for instance, one way we changed that approach is by partnering with care managers. So Geriatrics is a corporate partner with the Aging Life Care Association, and that is a nonprofit association that houses certified geriatric care managers across the entire country. So in doing that, we've now just focused speaking to them, who are, mind you, a network of private concierge, senior care navigators and care planners. And now they have become our referral source when it comes to seeing, one, the crazy cases, and then two, saying, hey, we got a resource that Canterbury can just come on in and do a review on behalf of us. So we've switched the model a bit from that shotgun approach to sticking to who are the key partners that have, at least in the history of our client base, have given us the most referrals. And they have been indeed care managers. But hey, it could be concierge doctors. It could be, a wellness center. It could be an adult daycare center. It could be a number of those places, but you got to start the conversation. And thankfully, I started a conversation to where, having the opportunity to move into other sectors was fairly easy. But I wouldn't make that mistake. It wasn't a bad mistake. It was just a lot of energy, a lot of time, and a lot of money. But I advise anyone to start with, first, who is your local area agency on aging? And when you figure out what that is, those are the resource hubs for aging things, the whole spectrum of aging within your zip code. So you start there, and you want them to know you so that they can refer to you. And now you start, showing up, you do things for free, you start going to health fairs from the resource bank that they have, and you make yourself known. Now that's the bootstrap long way, but that's the way that's gonna be residual in the long term. So start with who's in your backyard, who needs you, where do you show up most that would probably benefit. It could be your kid's PTA, it could be, your church faith-based group, it could be where you volunteer for Christmas. It really doesn't matter. But the point is everyone's got a grandma, someone's got someone old in their life that they're caring for or worried about. So your market truly is infinite. I do advise now, if you can, look to the business that already serves that population and you just help them. That's going to save you way more time than chasing one or two clients here and there in the community, where you can go to a business that already has a load of people that they're seeing, and you just become an added service of their outreach. So that is really the key now, is doing it more on a business to business lens.
Yeah, I mean, that's such good advice. And to your point, I think to recruit patients, you got to talk about it. You got to be willing to give talks, talk about the problem, how you can help, provide a solution. But a website, just like opening up a business and having a website, does nothing. Like, I don't, as long as my business has been opened, I think like 2 people have found me on a website and booked. Everyone else has been like at a talk or known someone that was at a talk and said, hey, you should, look this person up.
Exactly.
But yeah, speaking. And then through your speaking, though, I mean, yeah, it did take a lot of your time and energy, but look where it's taken you as far as like your TEDx talk and being known as like a speaker. That's really cool that you're kind of the face of senior care pharmacy. And you're just so awesome that way. I love that.
Yeah, it's a huge blessing, man. You're right. Absolutely did not intend any of that. Like, that was not in the plan. If you thought I'd be some pseudo celebrity pharmacist, no, I don't even think I am, trust me. But that is the trajectory this has taken me, to get accolades from the American Society on Aging as the Aging Advocate of the Year is a huge honor, right? That's something I feel a pharmacist has never achieved among that society. To be able to say I have spoken and will continue to speak at the American Geriatric Society in the 3rd, 4th year of my business, those are phenomenal dreams I've had as a student, was like to speak at a conference or get published, like, or have a clinical study where I could partner with Duke providers and literally pilot a precision medicine Deprescribing initiative with African American patients. Like, that's a dream for me. So yes, it paid off in different ways. And yes, it was an investment, but my God, it was a huge blessing. And I never thought this would be what I can accomplish at all. So super cool.
And very inspiring for people like me. So you spoke, you work with area businesses, especially case managers, to recruit your patients. When you have your patients, how do you establish relationships with their providers so that, you make a deprescribing plan, but then get buy-in for the providers to like follow your advice?
Mm-hmm. Yeah. Yeah, it's a good question. And I find most providers are super receptive of this service in general. They're like, wow, I didn't think you could do this, especially when it's generally free for them. So really it starts with having the conversation up front. Once we get that patient buy-in, or at least that initial consult, all of our clients are signing a HIPAA release form anyway. So we have a contract that we're sharing with all the clinicians, just in a consent form saying, hey, look, we're just here to be an extra pair of eyes and be an extension of what you're already doing. We're not here to step on toes or diagnose. We want to simply help reduce pill burden. And here's where the what matters most conversation comes into play when we're communicating those concerns to the doctor. So it starts with breaking the ice, really. Sometimes it's showing up in person and just saying, hey, look, this is what we're doing. The family has us on board. We're hired for this service. Introduce yourselves. Start with their pain points. It's a lot in this system, but not many have a pharmacist embedded into their practice at all, let alone one that understands geriatrics and understands precision medicine and can help them with a number of HEDIS measures, whether it's maybe reducing falls or the falls risk reduction plan, or tapering an opioid, or reducing a symptom that they've had for whatever, but they haven't figured out why they're having those symptoms. Like we've gotten praise from primary care docs because of that extension and continuity of care. So because we have that established trust with the patient, we're not seeing them just once, we're seeing them for a year or 6 months. So when you have that continuity, it becomes kind of like, just clockwork, really, that we're here to be an extension of what you're already doing. So I say start up front. The minute you start having those conversations or your initial consult, you go straight to the who to remain docs. You fax them the retainer or your contract saying, hey, we need to release the records. And also, we want to help you. Let's have a chat. Can we get on your calendar? Or can I, buy you a coffee or something? But start with the dialogue. And again, lead with, we're here to have the patient in mind first. And we're here to help make your life a little easy. So you can ask us questions too. And it ends up being really a teaching in the moment opportunity.
Yeah. And when you have like a really well thought out plan backed by evidence, I do feel like it makes, their job easier. It's like, oh, yeah. You want me to taper this patient off whatever med, and here's the plan to do it. Yeah, let's do it. It's not like you're just recommending something and then they got to figure out how to do the rest. So a well thought out plan, I think, is super helpful, and also just helps establish some confidence in your skills, like they can trust you. So I think that's great. I love that. And of course, keeping the patient in mind first.
And once they trust you, then it becomes the waterfall just opens. Now you got more business from helping their other clients, and they're going to talk about you to your other team members. And it becomes, now you got to worry about how you're going to handle other patients. So it's a good problem. So yeah, it's scary at first, but trust me, they want you to support.
That's for sure. So not only do you work with patients and deprescribing, but you also teach healthcare professionals about deprescribing and kind of how to start their own, gig deprescribing. In 2 years, I think it's already been 2 years ago, I took Dr. Canterbury's course on the Deprescribing Accelerator. And what I loved most, aside from like everything I learned about deprescribing, was your one-on-one coaching, because you really do, like, there's a couple things that were completely out of my comfort zone, and you're just like so good as a coach to kind of like push you, but also encourage you at the same time. And when I was unsure of, like, really, will people pay cash? Just like, yes, Tam, do it. People will pay. So tell the listeners a little bit about the Deprescribing Accelerator, in case that it's something that they would be interested in taking and maybe starting their own gig using it.
Yeah, I'd love to. Thanks. So yeah, I started this Deprescribing hybrid coaching program 2.5 years ago. So Tam, I think you were my third cohort, or I think you're my second or third cohort. No, you were my third cohort. And funny, I just spoke to Megan like yesterday. So
that's awesome. Megan was in my cohort with me.
Yeah. So no, I basically, even in starting geriatrics, we all have this awesome skill set of Deprescribe. And what I found when I had, my cases was that there's a ton of new information that just wasn't taught in school, period. And I wasn't as comfortable with like knowing which resources to use or where to start. So I felt, look, we've got 10,000 older adults turning 65 every year, every day. We've got a huge need. It was like 1% of pharmacists are even geriatric trained. Why aren't we teaching not just pharmacists, but nurses, but social workers, but other future prescribers on what deprescribing means for an older adult? And talking to clinicians and doctors are like, we don't learn this. We don't get this. So I'm like, wait a minute. People who have all the power in prescribing don't even know the power of deprescribing. So I said, you know what? As I'm researching all this stuff for me, how about I create a course that not only gives you some of the basic core tenets of deprescribing implementation, but also how can I help you make a cash-based business out of this? How can you monetize that? Because let's be honest, this isn't a skill set. It's a very niche skill set. It's new stuff. The term was only coined in like 2014 or something, 10, 20 years ago at that. So, I mean, it's something that I feel in order for us to be better providers, we have to know this, no matter who you are. And that's why I'm like, it shouldn't be just a doctor or pharmacist. Like, caregivers can become prescribing advocates. So I create this hybrid program where we cover, live sessions for about an hour and a half each week, covering opioid prescribing, dementia prescribing. What are the top common side effects and conditions we see in older adults? Prescribing for herbals and OTCs. How do we use precision medicine as an avenue for prescribing, right? Understanding the aging landscape, and then how to advocate for families to become prescribing advocates. So the truth of the matter is, in starting this company, I had a crazy case where I was able to help a family get off 36 meds down to 8. And we cover that in our program in a couple of months, mind you. So I'm like, dude, if I can do that alone, why can't we all do it? And I got paid to do that, like, I don't know, $500 for the review, $500 to show up in the doctor's office. So like $1,000 for literally one review, which changed their lives forever. We all can do that, right? So I created this program literally to house all the how-to knowledge that I've found and I've researched that it's all evidence-based. It's not just me pulling stuff out my hat. And so I'm looking at the USD Prescribing Research Network, Australian Research Network, Canadian Research Network. What's the Fortalist? What's Stop Start? Like, all these things I did not know, even with my board certification in geriatric pharmacy. It just was like, wow, there's a whole world. Choosing Wisely campaign, understanding the Robert Wood Johnson Foundation, which funds prescribing efforts, knowing that the NIH has a dementia impact collaboratory to fund people like us who want to prescribe for people with dementia and chronic conditions. Like, there's a whole world. I didn't even know the Biome came from the VA. And like, wow, we're doing it in our own states, in our own country. Why aren't we doing it everywhere? So they just got my exciting wheels turning to like give you guys the quick and dirty of the clinical piece. But more importantly, with our coaching, we're now pushing you through the business side. Like, how do you put yourself on the market? How do you position yourself? How do you know the niche problem that you're going to solve? How do you make a model out of this concierge practice? So that, to me, is the beauty of this, is we're giving you the clinical, sure, we're going to get your 15 hours of live CE, but really the most important part is having the community of prescribers who finish. And now you've got, Tamara Ruggles, who's freaking killing it, one of our rock stars. We've got, a geriatrician by the name of Tony Miles, who just graduated. We got a psych NP nurse in Virginia. We've got tons of LTC pharmacists who've taken our program, who are now using us either within their job to become better entrepreneurs, or going off and starting their own thing. And I mean, whether it be with yoga, whether it be with, diabetes, health and wellness coaching, like, people are using this to become force multipliers in their day-to-day. And I just love seeing my students thrive. We've had about 20 students graduate since inception. We usually do things kind of small. We usually have classes of 3 to 5. Twice a year. We have essentially year-long cohorts now. When you had it, it was like a couple of months. Now it's a year-long, so that, people like you want the continued coaching and like encouragement. And I think that's the biggest barrier to success, is we get into our own heads and we end up just kind of losing the momentum, or we don't think it's possible. And I'm like, no, I'm the dude who says it's freaking possible. I'm your Morpheus. You're in the Matrix. You got to take the red pill, do it, and you'll be surprised what's around the corner for you, because you get your passion back and your patients get their passion back. So that's what we want to do. So
yeah, what I love about it too is like the people who I've talked to have taken it, that everyone's kind of taken it and done their own thing with it. Like, the person that was in my cohort really loved yoga, and she was going to combine yoga with deprescribing. And so I started a clinic. Other people are doing other things, but we're all just kind of taking what we learned and using it in our own unique way that we're passionate about. But the big takeaways, like, you kind of introduced me to pharmacogenomics, again, because in school, it's like, well, pharmacogenomics is like the way of the future, but no one's really doing it now, and it's so expensive. Mm-hmm. But then, like, even just like your model on pharmacogenomics, I'm like, I love that. I'm going with that for sure, so then just like expanding that. And then of course the one-on-one coaching is awesome. So if anyone's interested, check Dr. Canterbury's course, the Deprescribing Accelerator, out. Maybe it's something you want to try. I certainly encourage it. So for the end here, since it's December and it's already coming up on the end of 2024, I thought it would be kind of fun, especially as we've become friends, to end with like a gratitude and a goal. Like, what is something professionally we're really grateful for in 2024, and what's a goal we have for 2025? And I'll let you go first because I'm super curious what you're going to say.
Yeah, there's so much to be grateful for sure. And I would say this year were some new frontiers for me, new rooms. I'm grateful for being a little afraid. And I mean that by I still have more to do that's going to globally impact the world. And having that fear and pushing past the fear, right, is what I know tells me that I'm still not there yet. And I need to mentally grow to like hit that next level. So a part of this is speaking, for instance, in Chicago. This was a really new venture for me, was speaking to what are called risk managers, people who literally do the quality assurance for like SNFs, ALFs, and sometimes they're nurses, social workers, or non-clinical, but they literally are the P&T committees for falls, NICQs, blah, 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 blah. And to be on a stage, to go over that very same 36 medication case and then get their wheels turning on like, you know what, why aren't we using pharmacists or specialists in deprescribing as like a part of our harm reduction strategy? Yeah, you may get a report from Omnicare for like, all right, you got this many anti-psychs, but like, are you actually implementing anti-psychotic stewardship? Like, are you actually looking at everything in the whole picture? So to me, I have immense gratitude to be invited on that stage, but then to now build partnerships with some of these pretty robust facilities to know that, hey, you may be doing some things great with falls risk prevention by going to the room and looking for carpets that are out of place, et cetera. But are you looking at the key picture of all their meds? And that's a dialogue that people were like, we kind of do it, but we actually don't. So to be the only pharmacist in that room and to show how we can have an arsenal of geriatric pharmacists and even social workers and nurses who advocate for deprescribing, I think is going to become a force multiplier for the global vision I have of making every senior living facility a center of excellence for deprescribing. So that's my biggest gratitude moment in terms of achievement and I think what's to come.
That's amazing. I was thinking about what I'm grateful for, and there's so many things that come to mind, of course, because it's been a really great year professionally. But I think I'm just really grateful that the Deprescribing clinic is still open. Like it hasn't failed. I continue to get clients because when you start a business like that, you think like there's that fear of like, this could be a total flop. Like I might open this and it might fail. And I was okay with like taking that risk when I opened it, but I am really grateful that I still have patients coming and that it's still going strong. So that
you don't just have patients coming, you're underselling your awesomeness. You literally had media features for your company. Like you literally had the news highlight how awesome your work has been. And it's a model that I feel, frankly, no one has done in this country. Let's be really honest. It is called the Deprescribing clinic. And it's a cash-based model. It's in an outpatient setting. Like generally a primary care doc can do that with their own practice. You're doing this as a pharmacist. Do you know how amazing that is? So like you're such an inspiration to other people who are like, oh my God, yeah, I know her. Wow, I didn't realize. Yeah, like no, you are setting a paradigm that's super high that is going to change, and it has changed healthcare. So it's not just that it's open. Yeah, this is like the second, third year, which is, the more critical years. But you've already made decent cash flow from this. Like, you've had success and you've got patients who still want to come back and like refer. So I want to help you see that it's way more than that. You're changing the practice of pharmacy, which is so rewarding to see from a student, but also from a colleague and friend. So you're killing
thanks,
it.
DeLon. You're awesome. See
Yeah.
how good of a coach he is, you guys. It inspires you to keep going.
Yeah, man.
Okay, so 2025, I'm sure it's going to be a big year for you. What's
Yeah.
your goal? What's one of the big goals you have for 2025?
Dude. So I mentioned I was still a little bit scared about some stuff. My biggest goal is, and I'm already having it started now, but my goal is having a sales and marketing team. It is time. So I am hiring, I have interns already dedicated to this, but now my focus is bootstrapping and going to these communities like everyone else. And instead of me being the guy, it's like, all right, I need people to go out, book my calendar with making these services accessible to all instead of me doing it alone. So I've always had a fear of hiring. I've had an executive assistant this last year, which has been amazing. Steph is great, but now it's like I need a sales force going. So that's one of my goals. But in terms of more like grandiose clinical, so we're going for another grant. So I mentioned that Deprescribing grant with the church. That was a mini grant we got from the US Deprescribing Research Network. We're going for a larger one. So we're going for a larger pilot study grant with Duke and the AME Zion churches. We're also looking to partner with VCU. They have a geriatric precision medicine program, and we're looking to go for maybe another PCORI grant to scale this regionally across other AME Zion churches in the country. So we're hoping to make a faith-based Deprescribing precision medicine thing become the norm. So that's another study we're going to go for. And what else? I have a lot of goals. I have a lot of dreams. I'm trying to do less is more this next year. I say this every year. As long as I stop traveling and stop doing all the things, but I'm trying to do less is more. So I'm trying to do less going everywhere and being everywhere all at once and letting things just kind of flow and being a bit more grounded and intentional in my focus. So I'm super excited to that mindset shift because I'm burning myself out a little bit, to be honest with you.
Yeah.
It's a little tiring, as you can imagine. So I'm looking forward to that. And I'm looking for just continued peace and helping more patients. Yeah.
Yeah. That's amazing. I love your grants and all the work you do with your grants, and the sales team sounds perfect for you. So that's awesome. So speaking of grants, that's one of my goals for 2025, and it's kind of out of my hands now, but I've been collaborating with North Dakota State University, and we've applied for a Transcend NIH grant to do pharmacogenomics testing in long-term care. And so if we get that grant, we would test 150 patients and kind of just track meds before and after, significant interactions, things like that. And so I'm really hoping we get that. We should find out in the next few weeks how it's going. But North Dakota State has been amazing to work with, and I'm really grateful for them because grant writing is definitely not one of my strong suits.
I'm so happy to hear.
Yeah, so that's great. And then I've also been working a lot with the provider CSAO to get to start billing for services. And so they've helped me get credentialed with North Dakota Medicaid, and we're working on some other things right now. So hopefully I'll be able to bill more for services for those that can't afford cash pay, which would be really great because there's a lot of amazing patients I want to work with that simply do not have the funds to pay. And unfortunately, I'm like too maxed out to be volunteering at this point. But so hopefully if I could start billing for services, that would really be helpful.
Yeah.
So, yeah, that would be great.
That's
so
awesome.
We'll see how things shake up here, but I don't want to take up more of your time. You've already been so gracious. But please tell all the listeners where they can find you.
Sure. Yes. Check us out on LinkedIn. Our homepage is geriatrics.org, Geriatrx as an X-ray, but also just look up DeLon Canterbury. You'll find us on LinkedIn. You'll find a link to the Deprescribing Accelerator within my bio. But we're everywhere. We're on YouTube. We have a YouTube channel. Check out our Red Pill versus Blue Pill series. And yeah, just Google us. You'll find us, do all types of podcasts and speaking engagements. And hopefully you can get some tips for your family or how you can start your own practice with our work.
Yes, be sure to check him out. DeLon is absolutely amazing to work with. So thanks everyone for listening. We appreciate it. And I won't have another podcast till January. So Happy New Year, everybody.